Okay, yeah, all right, so we'll kick off. So good evening, everybody, and welcome to this evening's GECO session, hosted by the Gastro Foundation in association with Project ECHO of the University of New Mexico. This is run every second week, as we know. Please, the chat will be open for questions, so post any that you want, or even better, put your hand up and you can answer questions in person. So today our presenter is Dr. Abdullahi Omar from Steve Biko in Victoria, and he's going to give us a presentation on conventional therapies in IBD, and then after that we'll have a discussion. So if you want to start sharing your screen, and we can get going.
Thank you, Prof. Watermeyer. Can you hear me well?
Yes, you're very audible.
Okay, thank you so much, Prof. My name is Abdullahi Hadi Omar. I'm one of the medical gastroenterology fellows at Steve Biko Academic Hospital, University of Victoria. Professor Watermeyer is the facilitator of this talk today, and I'll be talking about conventional therapies in the management of inflammatory bowel disease. So, as we know, anti-TNFs and other newer biologics have revolutionized in the management of IBD in the past decade. Unfortunately, most of these drugs are quite expensive, and its use is often restricted in resource-limited environments. Hence, the need to optimize conventional therapies to achieve maximum efficacy. And often, most of the time, are the only agents at our disposal in sub-Saharan Africa and need to be explored fully before pursuing biologics. And the conventional therapies I'm going to talk about are 5-aminosalicylates, corticosteroids, methotrexate, and Thiopurines today. So their use are quite different. They're used differently in ulcerative colitis and Crohn's disease. So I'll be discussing them separately. So the use of ulcerative colitis, conventional therapies in ulcerative colitis depends on 3 categories: the disease extent, the severity of the disease, and the prognosis. And we assess that using the Montreal classification of ulcerative colitis. So depending on the anatomy, if it's proctitis or left side disease or extensive disease, and also the severity, we can assess using mild, moderate, or severe disease. So we mean mild by less than 4 stools per day, no systemic toxicity, and no raised inflammatory markers. Moderate severity is 4 to 6 stools per day, minimal systemic inflammation, and severe, it's more than 6 stools per day, systemic toxicity, and raised inflammatory markers. We can also use Paris classification also. Instead of 3, this one can be, the extent can be divided into 4. It can be proctitis, left-sided ulcerative colitis, extensive disease, and pancolitis. In terms of severity, it can be either never severe or ever severe, using by pediatric ulcerative colitis activity index more than 65. We can also use endoscopic assessment of severity using Mayo endoscopic subscore, which can be divided into normal, mild, moderate, and severe ulcerative colitis. So let's start with the 5-aminosalicylates. So it can be 2 different formulations: suppositories or enemas, or oral formulations. These are some examples that I've taken, the ones available in sub-Saharan Africa, usually in South Africa and other African countries: Asacol, Bentaza, and sulfasalazine, and the dosages are available here. So these are anti-inflammatory agents, and they are used, depends on disease extent and severity, and the end effect is a topical effect on the gut mucosa. And the different types does not usually influence efficacy of these drugs. So let's start by ulcerative proctitis. So it can be used 5 assays to induce remission or to maintain remission, both of them. So to induce remission, we can use rectal 5 assays at a dose of 1 gram daily, and suppositories are preferable to enemas because they can bypass rectum. And to maintain remission, you can continue with the same dosage 1 gram daily, and it can be decreased up to 3 times a week over time when patients are in deep remission. Left-sided disease or extensive disease also can be used to induce remission and also to maintain remission. So to induce remission can be, it can be used to a combination of rectal 5-SAs plus oral 5-SAs. And a minimum of 2 grams per day for mild disease is recommended. And for more severe diseases, you can go up to 4 grams, ideal as a single dose or twice daily dosing. Also can be used 5-SA enemas or foams are options to use. Usually foams can reach up to 20 centimeters and enemas can reach up to the splenic flexure. They are quite expensive and usually they are not widely available, these ones. So to maintain remission in the left-sided or extensive disease UC, you continue the same oral 5-SA therapy at the dose that proved efficacy. So usually it's 2 to 4 grams daily, and patients on less than 2 grams daily are more likely to relapse. So as I mentioned, the type of 5-SA that you choose, whether Asacol or Pentasa, does not influence efficacy of the drug, and they are usually continued indefinitely. There are some scenarios where some can consider discontinuation in patients who are in deep remission more than 2 years, but it rarely happens. So these drugs are generally safe and well tolerated. There are few side effects that the patients can have, especially the sulfasalazine one can have sulfur side effects, sulfur-like drug side effects for patients who are allergic to sulfur can avoid these medications. Some of other side effects that can be seen are reversible oligospermia or folate deficiency. So it's recommended to do full blood count and liver function tests at regular intervals. So some also can carry, all 5-SAs can carry the risk of a renal dysfunction. So it's recommended to check the UNEs at 3 monthly, then annually. There is an 8% chance that some patients can develop paradoxical diarrhea. So it should not be confused with disease recurrence. So the second drug I want to discuss are corticosteroids. Corticosteroids are given to induce remission. They are never used to maintain remission. So also one of the indications for corticosteroids are patients who are admitted with acute severe ulcerative colitis. So corticosteroids are budesonide, which is approved for induction of remission in mild to moderate UC, and the dosage is around 2 milligrams twice daily for 2 weeks, followed by 2 milligrams once daily for 4 weeks. Patients with more severe colitis, treatment with conventional steroids like prednisone is indicated. Patients who are admitted with severe acute UC, IV corticosteroids are indicated to induce remission. So oral prednisone is usually given to mild to moderate disease, not require hospitalization, and treatment duration is usually 6 to 8 weeks, and you continue with 5-SAs for maintenance therapy, or you consider thiopurines and anti-TNFs. Corticosteroids are not used to maintain remission. As I mentioned, IV methylprednisolone is given to patients admitted with acute severe UC. Side effects of corticosteroids are many, and most of us are aware, like hyperglycemia, hypertension, infections, osteoporosis, the list goes on. So when patients are steroid dependent or steroid refractory, or they require more than 1 course of a steroid per year, you need to escalate therapy to add immunomodulators. And one of them is a thiopurines in UC. So these drugs are azathioprine and 6-mercaptopurine. They disrupt DNA replication of rapidly dividing cells, such as T lymphocytes. They also induce apoptosis. So these medications are not indicated to induce remission. They are indicated to maintain remission, and they take up to 8 to 12 weeks to start working. So I want to take a little bit of time to discuss about thiopurine metabolism, because it's very important to understand the metabolism of thiopurines to talk about their efficacy and their use. So as a thiopurine is metabolized into 6 mercaptopurine first, and then it takes up to 3 different pathways. The first pathway is the HPRT pathway, which will produce 6-thioguanine. That's the active drug that usually works for inflammatory bowel disease. The second pathway is the pathway of TPMT enzyme pathway, which the end result is 6-methyl-mercaptopurine. And the third pathway is the xanthine oxidase pathway, and the end result is 6-thiouuric acid. So the one that usually works for inflammatory bowel disease is 6-thioguanine pathway. So what are the common complications of thiopurines? The commonest one is nausea and vomiting and flu-like symptoms. And usually they resolve with switching from azathioprine to 6-mercaptopurine, because most of the metabolites that are produced from azathioprine metabolism to 6-mercaptopurine are the ones that are related to these side effects. The other side effect is pancreatitis, and usually it can happen within 1 month of initiation of thiopurines. So if a patient presents with abdominal pain 1 month after initiating thiopurines, we need to check lipase. And usually it's mild and dose dependent. And if a patient develops pancreatitis after initiation of thiopurines, we should stop the drug and we do not recharge. So thiopurine-induced hepatotoxicity, this is most commonly increased transaminase levels, and they resolve with dose reduction or drug discontinuation. This toxicity is related to the 6-mercaptopurine levels. That's the second pathway through the enzyme, thiopurine methyltransferase enzyme. So usually it happens around 8 weeks, mostly of 85% of patients after initiation of thiopurines. So less commonly side effects are idiosyncratic cholestasis and nodular regenerative hyperplasia leading to portal hypertension. One other side effect that can happen with thiopurine are alopecia, and usually it's a dose-related adverse event, so you can decide to stop the drug or reduce the drug levels. Thiopurine-induced myelotoxicity. This is one of the most serious side effects caused by thiopurine, and the incidence rate is 3% per patient year of treatment, and Asian populations can be as high as 15%. This side effect can occur anytime during treatment, and it can lead to life-threatening bone marrow suppression. So the most common abnormality is leukopenia. Also, pancytopenia and thrombocytopenia can occur. So there are some genetic mutations that are related to this thiopurine-induced myelotoxicity, and we'll discuss in a minute. So the first one is TPMT deficiency. This is thiopurine methyltransferase enzyme that metabolites 6-mercaptopurine into 6-methyl-mercaptopurine. So it's a deficiency, it's a loss of function of TPMT enzyme mutation, and usually it happens in 1 in 300 are homozygous and 1 in 10 are heterozygous. So if you are deficient in this enzyme, what is going to happen is that you will have a low TPMT levels, which will lead to shunting of the thiopurine metabolism into 6-TG pathway, which will have a lot of, it increased 6-TG levels. This will lead to high increased risk of neutropenia and also increased side effects. So it's recommended to check TPMT enzyme genotype or activity before starting treatment if your center can do these things. And if you find that it's homozygous or very low activity, you should avoid using thiopurine. If it's heterozygous or intermediate activity, you should use half doses. The second mutation is NUDT15 mutation, which is a gene that encodes for Nordics hydrolase 15. This is the enzyme that converts cytotoxic TG levels to non-cytotoxic TG metabolites. So when you have low levels of this enzyme, so the patient will have increased cytotoxic TG levels in the blood, which will lead to high levels of TG, more side effects like neutropenia. Again, it's the same genotyping is recommended. If it's homozygous, you avoid, and heterozygous, it's a half dose. There are very unfortunate patients which can have both TPMT and NUDT15 variants in combination. They even have higher risk of early myelosuppression. So thiopurines are avoided in these patients. So to avoid or overcome complications or inefficacy, metabolite testing is the best practice if your center can afford or you have that metabolite testing. So you measure the therapeutic range of the TG levels, which are around 235 to 450. You can measure it in the RBCs, and usually it's measured 4 to 6 weeks after initiation of the drug and after steady state is reached. So there are a group of patients which are called hypermethylators. These are patients which have, instead of, it's the opposite of the TPMT deficiency. These patients have high levels of TPMT activity, which means that the thiopurine metabolism is shunted to the methyl, instead of 6-TG, it will be shunted to methyl mercaptopurine pathway. So it shunts away from the 6-TG pathway, which is the active ingredient that works for IBD treatment. This will lead to reduced efficacy and increased side effects. And I've already mentioned that increased levels of methyl mercaptopurine is associated with increased hepatotoxicity. So a low dose of allopurinol can be used to block the xanthine oxidase pathway, which increases shunting into 6-TG pathway, which becomes more efficacious. How it works, I could not find out, but that's it's used for allopurinol. So we use weight-based dosing for thiopurines, as a thiopurine is 2 to 2.5 milligram per kg, and 6 mercaptopurine is 1 to 1.5 milligram per kg. This is not ideal because metabolism of thiopurines is not uniform in the general population. So one of the clues that can give you that the drug is therapeutic is lymphopenia, which is not less than 0.5 after starting of the drug, or a raised MCV levels, a rise of 7 above baseline. So how do we monitor thiopurines? We monitor full blood count at baseline, 2 weeks, 4 weeks, 8 weeks, and then 12 weeks, then 3 monthly. We also monitor liver function test. We do it initially monthly, then 3 monthly when the patient is stable. We continue monitoring of the entire duration of therapy because I have mentioned side effects can happen. Myelosuppression can happen anytime during treatment, even 5 years after starting treatment. So thiopurines and malignancies, these drugs have the greatest risk for incidence in cancer rates, especially in older IBD patients. And these are mostly urinary tract cancers, lymphomas, and non-melanoma squamous cancer. Lymphomas and thiopurines typically is a post-transplant EBV cell lymphoma. So the risk becomes significant after 1 year of exposure of the drug. And usually younger males have the highest relative risk, but the absolute risk is highest in patients more than 50 years of age. It's 1 in 300. So there is also an increased risk of hepatosplenic T-cell lymphoma. This is a rare cancer linked to thiopurine use. So usually it happens in monotherapy or in combination with anti-TNFs. Again, this is also happens mostly in young males. Methotrexate in ulcerative colitis. It's recommended against use in all guidelines. It does not work for remission or maintenance. Now let's talk about conventional therapies in Crohn's disease. So the choice of therapy here also depends on location, severity, and prognosis. Again, we use Montreal classification for age, behavior, if it's non-stricting or structuring or penetrating. The location, is it terminal ileum or colon or ileocolon or upper GI Crohn's, and the presence or absence of perianal disease. So oral 5-ASAs usually generally very ineffective in small bowel Crohn's disease. So they are no longer used, they are no longer indicated. There is modest efficacy in chronic Crohn's disease, and especially salazopyrin. If a patient with Crohn's disease has proctitis, you can use rectal 5-ASAs may be used. Corticosteroids used in Crohn's disease, it's very similar in ulcerative colitis. Short courses to control symptoms should never be used as maintenance therapy. In contrast to ulcerative colitis, ileal release budesonide is effective in right-sided Crohn's disease. What do I mean by right-sided Crohn's disease? Crohn's disease that's localized to terminal ileum and the cecum, and is the first-line steroid of choice for mild disease, ileocecal Crohn's disease. Most severe disease requires conventional steroids like oral prednisone or IV methylprednisone. So patients with Crohn's disease, we need to identify early patients with high-risk patients who are likely going to develop severe disease over time. So what are the predictors of a poor outcome? A young patient, a young age patient who needs for steroid use, extensive disease, someone with previous surgery, perianal disease, strictures or fistulas, and patient who smokes. So these are good candidates for thiopurine use or methotrexate at diagnosis. So the approach of thiopurine use is the same as ulcerative colitis that I've just discussed. Methotrexate is effective in Crohn's disease in contrast to UC. So can be used for induction or maintenance of remission. And the dosage is 25 milligram intramuscular or subcutaneous weekly with folic acid. And for maintenance is 15 milligram weekly intramuscular or subcutaneous with folic acid. One of the common side effects of methotrexate is liver dysfunction and interstitial lung disease. And a regular monitoring of liver function test is recommended in patients with methotrexate. Women of childbearing age also should be avoided with methotrexate, and it's recommended to take informed consent before starting methotrexate. So conclusion, conventional therapies still remain the mainstay of treatment, and they need to be explored fully before pursuing biologics. 5-ASAs are excellent in UC, poor efficacy in Crohn's disease. Corticosteroids should be used only as a short course for induction of, but never for maintaining remission. Thiopurines are effective in both Crohn's disease and ulcerative colitis, and methotrexate is only used in Crohn's disease. Thank you.
Fantastic, thanks so much. Right, that was an excellent overview, and I think you've covered pretty much all the points that I usually like to make about these drugs. Just a couple of things that I've jotted down. I don't see any questions in the chat, but we can come to that just now. So firstly, you mentioned the Paris classification of IBD. That is specifically for pediatrics and not for adults. Okay, so we still use the Montreal classification in adults. 5-ASAs, just to point out that the minimal dose, you did allude to this, is 2 grams per day. Please don't use it as a lower dose than that. It really is pretty homeopathic at lower doses. Yes, I do agree that 5-ASA should be considered lifelong, but there is an exception, and that's on patients who are on anti-TNFs who are in deep remission, which I would consider clinical, endoscopic, as well as biochemical remission, and who are on concurrent 5-ASAs. Here we have some quite good data to show that 5-ASAs do not confer any additional clinical benefit. And obviously they carry a higher pill burden. So that's the situation where you could just discontinue the 5-ASAs and just continue on with the anti-TNF therapy. You did allude to the paradoxical diarrhea that 5-ASAs can cause. So please, under no circumstances, start them for the first time in a patient with acute severe ulcerative colitis, because if you do get diarrhea, it really complicates the story. Now you don't know if the patient is responding to the steroids or whether they're an incomplete responder. And certainly 5-ASAs are not going to touch acute severe ulcerative colitis. So all you're doing is shooting yourself in the foot. Of course, when the patients go home, then you will obviously start the 5-ASAs. Sean, I see your hand up. Do you want to unmute yourself and ask your question or make your comment?
Hi, Prof. No, I think you answered my question before I could answer. It was related to 5-ASAs and in discontinuing in patients who are on TNFs and responded to therapy in deep remission.
Absolutely. I don't know if you listened to my colorectal cancer talk that I gave for the GI Foundation the other day. So many experts across the globe feel that you do not need to continue 5-ASAs for chemoprophylaxis in ulcerative colitis. They feel, and certainly this does appear to be the case, that this inflammation for colorectal cancer, it's driven by the inflammatory response. So if you have patients in deep remission, you've probably already done the best thing that you can do to reduce the risks of developing colorectal cancer. In my practice, we don't always have access to anti-TNFs, and very seldom are we able to get our patients into completely deep remission. So they will continue to have a risk of colon cancer, and I just continue them indefinitely, whether that be right or wrong, and that is my personal take on the matter. In terms of corticosteroids, we tend to use prednisone, and it's usually at 1 milligram per kilogram for the oral formulation. And just to point out, don't go above 60 milligrams. There's no point. So if you've got a 100-kilogram man on steroids, don't bother to give him 100 milligrams. It's really pushing the boat. To 60 milligrams is fine, and then you taper by 5 milligrams a week. So usually it's about a 3-month taper, and this gives the time for azathioprine, 6-mercaptopurine, or in the case of Crohn's, methotrexate, time to actually kick in, because they need 2 to 3 months. Nassif, your hand's up. You can go ahead and ask a question or make a comment.
Thanks, Prof. Thanks for a wonderful presentation. Just a practical question in terms of initiating anti-TNFs.
Yes.
In the presentation, clearly it depends where you are. But let's say resources was, let's say most of us end up in private practice and we have this conventional therapy. Just some practical advice. We'll start on the conventional therapy, but where access to anti-TNFs is not as hard as what it is in state. There's some practical advice as to when you'd start the anti-TNF and when you stop the, at least sort of that sort of balance of initiating anti-TNFs in that context. Thanks, Prof.
Sure. So as Dr. Omar already said, it very much depends on your extent of disease and your severity of disease. So if you've got patients who've got UC and they've got mild disease, you're very, very likely going to get away with oral and topical mesalazine. Certainly, 6-mercaptopurine and azathioprine work in UC. Methotrexate doesn't. So for patients with more moderate disease, you may want to start them. Of course, the first prize would be putting the patient straight onto an anti-TNF, and I would certainly go that route in somebody who has had acute severe ulcerative colitis and has required rescue therapy with infliximab. I would continue it going forward. For other patients with more moderate sort of outpatient disease, obviously, if they fail conventional therapies, and I certainly wouldn't give them much longer than 6 months at max before then escalating to an anti-TNF. Okay, before I carry on, there's just 2 questions on the chat. I'm just trying to see here. Okay, combination therapy with infliximab for immunogenicity. Example, azathioprine and sonic. Absolutely. So there's 2 points you need to make here. The first is that not all anti-TNFs are as immunogenic as the others. Infliximab is chimeric, meaning that part of it comes from a mouse, and this makes it highly immunogenic. So you're going to get antibodies to infliximab in far more patients than you're going to get antibodies to adalimumab. So certainly with infliximab, you definitely want to use a combination therapy with either azathioprine, 6-mercaptopurine, or methotrexate. The SONIC study was, of course, the study that showed in the setting of Crohn's disease that the combination of the 2 was better than monotherapy with either, and that this was largely due to reduction in immunogenicity and improvement in trough levels. Similar study was done in ulcerative colitis called the SUCCESS trial, also showing combination of infliximab the thiopurine was superior to either alone. Adalimumab, the jury's out. Certainly, you can use it as monotherapy if you want. And this is one of the indications would be in patients who you don't want to use a thiopurine, such as a young male, an older patient. Then adalimumab would be a biologic of choice if you want to use it as monotherapy. On your drugs, vedolizumab and ustekinumab, you do not need to combine them with an immunomodulator. It doesn't make any difference. And was there anything else? I think, Matt, I saw something from you. Start anti-TNFs earlier in adolescents and younger patients. Absolutely. We know that the longer that you have these diseases, the more likely you are to run into complications. And often these patients have a more aggressive phenotype. So yes, low threshold, especially in children, because if you don't treat them properly, they get growth delay and they get pubertal delay. So you really want to get on top of inflammation in a child as quickly as possible. Sorry, I did see something from Mashiko. Okay, she says, thank you for a wonderful presentation. Don't forget the role of immunogenicity. Sorry, Mash, you just answered that as combination for immunogenicity. All right, so that was your question. Okay. All right, so just back to some of the other things that I wrote down, jotted down. Nausea and vomiting with thiopurines. Yes, you're absolutely right. You can get away with it by switching to from azathioprine to 6-mercaptopurine. Another possible way is by splitting the dose. So giving half in the morning, half in the afternoon, and sometimes that does improve the GIT side effects. And would certainly be cheaper than switching to 6-mercaptopurine, which is actually an expensive drug. In terms of the allopurinol, so how it works is by blocking the xanthine oxidase pathway, and this causes preferential shunting down towards 6-thioguanines. Okay, so it reduces the levels of the MMPs, which are the ones that give you the drug-induced liver injury. Just some points about using allopurinol in combination with azathioprine or 6-mercaptopurine. You've got to be really careful. These patients can run into huge problems with neutropenia. So the type of dose that one would give would be 100 milligrams of allopurinol, so not the 300 milligrams we give for gout, and you would use the azathioprine or 6-MP at a half dose. In South Africa, we don't have the ability to do thiopurine metabolite testings, and I would strongly advise against the strategy in our country. It's fine if you have access to metabolite testings, you can keep an eye on what's going on, but here you'll be fumbling around in the dark, and the next thing you've got a patient with neutropenic sepsis. Okay, what else? I'll write down here. Okay, thiopurines and malignancy. Okay, so the risks that we are all very aware of is lymphoma, okay, as well as non-melanoma skin cancer. And just to make the point that if you stop the thiopurines, the risk of lymphoma very rapidly returns to that of the general population. But non-melanoma skin cancer, that risk remains indefinitely when you have stopped the thiopurines. So one always has to just keep an eye out for those, even if they stopped their thiopurines 10 years ago. You didn't mention it, but thiopurines should really be avoided in Epstein-Barr virus negative individuals, particularly if they're young men, because they run the risk of developing a primary EBV infection, which can cause a rapidly progressive lymphoproliferative disorder, which can be fatal. So if you can avoid using it whenever possible in EBV negative patients, that would be ideal. And of course, we do EBV serology in all of our patients at diagnosis as part of our opportunistic infection workup. In terms of methotrexate, the nausea and vomiting that these patients often develop, you can reduce this by going slow. So I start with 10 milligrams the first week, pushing up to 15 the second week, then 20 the third week, and then 25. And then keep them on for 25 for 3 months, and then you go down to 15. And just often that gets around the nausea and vomiting, and patients find it more tolerable. And also just with methotrexate, don't take the liver function tests too quickly because you're going to get a fright. So wait a little bit before you actually start taking them. And then just finally, you didn't mention it, but traditional budesonide, the ileal release budesonide does not work in ulcerative colitis because it doesn't really reach the left side of the colon. But there is a preparation called MMX budesonide. Here, the budesonide is in a formulation which has an MMX release property, which allows the drug to be slowly released throughout the colon. So it works perfectly well in left-sided ulcerative colitis. Okay, and those are the points that I have to make on conventional therapies. Does anybody have any other questions? Mash, I saw BG on earlier. Any comments that you'd like to make?
Thanks, Jill. No, you've covered all the points. You did mention the issue that the screening for opportunistic infection still applies even with conventional therapies.
Absolutely.
So, and vaccination then, especially for Hep B, since it is available.
Absolutely.
If the patient hasn't been exposed.
Absolutely.
Yeah, everything else is. Thanks.
Yeah, no, I think everything's been satisfactorily gone over, and I'm sort of happy that you pointed out the issue with the allopurinol.
Yeah.
I think anybody in South Africa who wants to try that strategy needs to be very, careful.
Absolutely. Absolutely.
Yeah, thanks.
Absolutely. Anybody
Jill,
else? Comments, questions, Mash?
If you didn't have TPMT at your facility and the patient needed it, could you just start it and just monitor the full blood count and the differential?
Yeah, absolutely. I mean, that's what we always used to do. We
Yeah.
didn't have TPMTs available until actually it was Janine Hickman who did that all for her PhD on myasthenia gravis work, and she got that all and the ball rolling with us being able to access that. So when I qualified as a gastroenterologist, there was no TPMT testing. Yeah, sorry, Vijay.
No, I actually completely agree. I mean, when we all heard about evaluating for the enzyme activity and the genotyping, but for years we've been using azathioprine happily. And the key was just to keep an eye on the FBC, and I'm sure you will agree, Jill, it's very, very rare we saw a severe leukopenia.
Yeah, very rare. But we've had some, and they've certainly had life-threatening complications, but I agree with you. If we have 2 or 3 a year, it's a lot. We do see quite a lot of patients who drop their white cell count. I'm not worried about the lymphocyte count. I want them to have a lymphopenia because it means the drug's working. As Dr. Omar pointed out, please don't let it go below 0.5. But I want a lymphopenia, but I do not want a neutropenia. So if a patient comes in, they've been on azathioprine and they're having their blood checked, and you notice that they've got, I'm not talking about a neutrophil count of 0. whatever. I'm talking about someone who's just a little bit low. What I tend to do is I tend to stop it for a week, recheck the full blood count, make sure it's bounced back to normal, and then just restart it at a lower dose. And usually you can get away with that. Yeah, and don't be lulled into a false sense of security if you have a normal TPMT genotype, because that only accounts for, I think it's about 80% of the neutropenias that occur with this mutation. There are many other mutations that you can get in the TPMT gene. So don't be lulled into a false sense of security just because you have a normal genotype.
Yeah.
All patients need monitoring lifelong. And this is not like the pancreatitis that you tend to see it within 3 months of starting the thiopurines. You can get neutropenia 20 years after being on a stable dose of azathioprine. Any other questions or comments?
I just a final comment as a last one before everybody else. On the 11th of December, we're going to have our feedback session on the whole 2-year curriculum. And I really like all of you to be there because some of you joined while we were already in process, just to find out how you're finding this, because it means next year, January, we're supposed to start a new cycle. So we can discuss the value and the topics and whether you're happy with the format or whether we should consider maybe changing things up. So please, I really, really appreciate you to attend on the 11th of December. So nobody's presenting, just a feedback chat about what we've been doing so far in the last 2 years. Thanks, Joe.
Thanks. Sorry, I see my video was off that whole time. It wasn't meant to be. Okay, so I'm just going to close up then. So it was short and sweet, and I think that's all you actually need to know about conventional therapies. I don't think you need to know anything else at this point in time. So first of all, thanks very much for that excellent presentation. I thought it was a really good overview. Short, to the point, succinct, exactly right. Thanks to ECHO University of New Mexico and ECHO India for their team for their support. The recordings will, of course, be available on the foundation website. And of course, as always, thanks to the foundation, thanks to Karen. And our next meeting will be on Monday, the 27th of November. That's in 2 weeks' time. We're going to be covering advanced drugs in IBD, which is a far bigger topic than conventional therapies, which has just shown, I think, how far IBD has come over the last 20 years. Anyway, good night, everybody. Have a good evening, and I'll see you in 2 weeks' time. Bye.